right. Hello, everyone, and welcome to today's webinar titled Customizing Syndromic Respiratory Panels, Maximizing Patient Care Through Flexible Testing Strategies. This webinar is a part of the 10th annual Microbiology Virtual Event Series brought to you by LabRoots and is sponsored by Diasorin. For more information on our sponsor, please visit diasorin.com. I am Sydney McNeil of LabRoots, and I will be your moderator for today's webinar. Before we begin, I would like to remind everybody that this event is interactive. We encourage you to participate by both communicating with other attendees using the group chat and by submitting any questions that you would like to have our speakers answer live following the presentation. If you happen to have any trouble seeing or hearing the presentation, please click on the Help button located in the navigation bar at the top of your screen. Okay, now let's get started. I now present today's speakers, Doctors Kaisha Gonzalez and Heba Mostafa. For a complete biography on our speakers, please visit the presenters window. Kaisha and Heba, you may now begin your presentation.
Thank you for the introduction, Sydney, and thank you everyone for joining us today. For our objective, we'll cover the global impact and the clinical challenges associated with respiratory infections. Additionally, we'll discuss the importance of diagnostic stewardship in the laboratory testing and trying to emphasize the need for that flexible diagnostic methods. Lastly, we'll explore the clinical benefits of customizable respiratory target selection and syndromic panels. So now let's dive into the respiratory infections and explore why flexibility is the name of the game. So respiratory tract infections are a significant global health concern due to their high rates of illness and death. Most respiratory infections are caused by viruses, followed by bacteria and other pathogens such as fungi or even mycobacteria, or even a combination of these leading to co-infections. Now, the incidence of these infections varies with the season, with some typically occurring during the fall and winter, such as influenza, and other infections more common during summer, while others occur all year round. Some additional facts about respiratory infection: they contribute to 6% of the global disease burden. They are highly transmissible and can easily spread from person to person or even from an animal to a person. They represent 60% of the hospital's emergencies. It is estimated that the annual cost of these infections in the US is over $87 billion, involving both direct and indirect costs. The prevalence of these infections is high in susceptible populations and causing high mortality rates. They are a major cause of outbreaks and pandemics. And lastly, they account for the majority of antibiotic prescription, even though the majority of these infections are caused by viruses. Now, respiratory infections present some of the most complex diseases when it comes to making clinical decisions. What do I mean by that? Well, the clinical presentation and severity can actually vary widely. The clinical spectrum, and it is very inconsistent from person to person. Symptoms range from no symptoms at all, from mild infections to severe or even fatal disease. This inconsistency is usually influenced by various factors such as the causative agent or even the host immune response, as an example. Not only that, but patients also can exhibit nonspecific symptoms. They are common to both viral and bacterial infections, which can lead to that diagnostic uncertainty. And this uncertainty then can result in delay in diagnosis, unnecessary testing, and even overuse of antibiotics, even in cases of viral infections. This is why then testing is crucial for identifying the pathogen or pathogens responsible for that infection. However, clinical assessment alone is often not enough to identify that causative agent, especially for respiratory infections, which can also have a high likelihood of co-infections, up to 62%. It is also important to take into account that the approach of laboratory testing depends on the severity of the illness, the clinical syndrome being presented and evaluated and the patient. So it's then important then to use that right test for that right patient at the right time to then refine that diagnosis, detect risk, and then determine the best therapies for that patient. Which leads me to then the importance of accurate and timely diagnosis to guide patient management. Does the patient need admission, isolation, additional testing, or even a different therapy to improve prognosis? And this is particularly actually important when considering then antimicrobial de-escalation, as we know inappropriate antibiotic use can actually lead to poor outcomes, longer hospital stays, and even high mortality rates for those patients. So how can then laboratory address these clinical challenges and still maintain a good balance in patient care? Well, by engaging into diagnostic stewardship. So imagine a healthcare system, right, where every diagnostic test is actually carefully chosen based on its potential to impact patient care. And this is actually the goal of diagnostic stewardship. In today's healthcare system, there's really a growing concern about the overuse or misuse of diagnostic tests. This is not only leads to unnecessary costs, but also can result in misdiagnosis and inappropriate treatments. So diagnostic stewardship then aims to address these issues by promoting the careful use of diagnostic tests and ensuring the right test is used for the right patient at the right time. Now, the practice of diagnostic stewardship is not only about reducing costs and improving accuracy, it is also about promoting evidence-based testing to ensure that the lab results are used effectively to guide patient management, which then results in diagnostic stewardship working in partnership with antimicrobial stewardship to prevent the overuse of antibiotics and the development of antimicrobial resistance, then allowing then as the overall goal high quality patient care. So let's talk about what it means the right test, especially in the context of respiratory infections. I already mentioned briefly some of the challenges associated with respiratory infections, right? So how then you tackle that right test? And this is actually a great question because especially considering that laboratory results influence up to 75% of medical decisions, which shows how important picking the right test is. Well, I can tell you that testing for respiratory infections should not be one size fits all. It actually requires flexible strategies. And what I mean by that is that, okay, you need to consider the causative agent, its seasonality, geographical patterns, the ability to cause outbreaks or resurgence, and whether it is self-limited or it requires treatment. And of course, you need to consider who you are testing, the patient's age, the immune status, and even any risk factors. Even knowing the travel history of the patient can actually identify potential exposures to unique pathogens or even travel-related infections, which then can influence your testing algorithms. Are you going to do targeted testing versus syndromic? If you opt for the targeted testing, can you do reflex testing in-house? What guidelines are available to help maximizing your options and then select the appropriate test? Are there any reimbursement consideration to take into account? And the answer is yes, by the way. So how can then I effectively manage that cost while ensuring that clinical utility and minimize the redundant laboratory testing or even resources consumption? Considering all those factors is then when selecting the right test is actually very important, given that making the right choice not only impacts cost, but also directly affects patient care. So knowing now all the unique needs of challenges associated with respiratory testing and the importance of diagnostic stewardship, we actually recently conducted a retrospective analysis evaluating the 2022 and 2023 respiratory disease season. Our goal was actually to examine the impact of seasonality and patient demographics, while at the same time trying to evaluate the benefits of having a flexible and customizable diagnostic respiratory syndromic panel. Back in 2022 and 2023, between October-April months, study was carried out across 6 geographical diverse clinical sites in the US as part of the FDA 510K submissions for the Liaison Plex and the Liaison Plex respiratory flex assay. Briefly, The Liaison Plex is a new instrument sample to answer system that can accommodate up to 6 random access modules for sample processing. The instrument software allows you to create user-defined custom panels where you can view and pay only for the targets that you select, but also has the ability for you to go back to those runs and select additional results without the need to rerun additional tests. The Respiratory Flex assay is also a new customizable syndromic molecular panel. The panel allows you the detection of 19 respiratory targets, 14 viral and 5 bacterial targets, all in one small consumable. So overall, in the study, we identified 1,520 positive nasopharyngeal swab specimens from patients exhibiting respiratory symptoms. As part of the retrospective analysis, the results were stratified by age in this table. The positive samples were divided in 3 groups based on age. You have the young population from 0 to 21 years old, adults 21 and 65, and the elderly patient beyond 65 years old. The overall detection rate for this target ranged between 0 to 23%. Most of the positive samples were under the young population, with 69% distribution, followed by the adults 21%, and the 10% for the elderly population. So one of the first things we wanted to determine was the pathogen composition of the overall detection rates of these samples. When we did that analysis, what we found is that 99.5% were viruses, while less than 1% were bacteria. And the results actually highlights the expected circulation of these pathogens, where viral infections typically occur during the fall and winter, while bacterial infections are less common. Now, I don't know if you know this and why we see this type of patterns, but it's particularly attributed to changes in the environment, like temperature and humidity, which can actually impact the transmission and the stability of viral particles, as well as the host immune response, and even the human behavior, like increasing indoor activities during the winter. So all that type of patterns and things that we do as humans all influence then the circulation of these pathogens among the population. When it comes to then, when breaking down then to the detection rates distribution of the bacterial pathogens, we saw that 0.5% detection rate of Bordetella parapertussis in the young population. Our detection rate actually matches the reemergence that the CDC reported during that season. This cases outside of the usual unusual seasonal pattern that is expected from Bordetella, maybe because children's immunity is decreasing in those regions. Some of them are not fully vaccinated, and the overall herd immunity is also low, just because of that COVID-19 measurements that we're still impacting us to this day. So then what about the breaking down of the viral targets? So what we observed is that the top viral targets were associated with the common cold, the COVID-19, and influenza. And this is actually important to highlight because current fall-winter targeted testing algorithms actually focus on flu A/B RSV and SARS-CoV-2, mostly due to reimbursement constraints or even available treatments. And this actually can then limit the detection of other prevalent viruses like enterovirus and rhinovirus and adenovirus. And why this is potentially a problem? Well, I can tell you that some of these viruses like entero and rhino can lead to high morbidity and mortality rate in high-risk populations, which I believe Dr. Mostafa will also highlight in her presentation. So in this scenario, right, if we are identifying the top targets, would have required multiple rounds of testing, which would have been expensive, time-consuming, and would have actually have some delay of diagnosis if targeted algorithms were used. However, of course, using syndromic panels for every patient would have been impractical due to that financial constraints. So there should be actually a balance where you can customize your panels based on the population that you serve, as well as taking into consideration any resurgence like we observed for Bordetella, And then this balance between that clinical utility and possible cause while maintaining then diagnostic stewardship is what should guide then respiratory testing. So next, we wanted to understand the distribution rates among the population that we tested. We found, as expected, that enter and rhino and adenovirus were significantly higher in the young patients, while SARS-CoV-2 and flu A were more prevalent in adults and elderlies. And then RSV was more prevalent in the young and elderly, as very typical behavior for this virus. Now, there are several possible factors why we see these patterns in these populations, right? For one, could be the lack of humoral immunity in the pediatric populations, some social behaviors, viral interference, or even the asymptomatic infections that are not captured can actually influence the prevalence that we can observe. Now, ultimately, the importance to understand is that when we are actually creating these testing algorithms, we really need to take into account the different susceptibilities, the prevalence, and also the respiratory etiologies to better serve these patients. Now, our next step, we actually did additional analysis to understand if it's really necessary to use a large syndromic panels every time for these patients to detect these infections. So we grouped the prevalence of each pathogen and divided the targets in 3 tiers based on the common size of targeted algorithms and then current reimbursement constraints for large syndromic panels. So group 1 consisted of a mini panel of 7 targets. Group 2 consisted of a medium panel that included 6 additional targets for that population with a total of 13. While then group 3 was a large panel with all 19 targets. What we found is that with 7 targets, over 85% of patients, positive cases were detected in tier 1 for all age groups. 85% of the infections for the young population would have been detected by only using 7 targets or a mini panel. That is 85 patients out of 100. Similar story for the adults. 88% or 88 patients out of 100 will need a mini panel to detect the most prevalent targets within this population. And for the elderly, you would have identified 96% of the infections by only using 7 targets. So what if we use a medium panel that can detect up to 13% or 13 targets? This would actually identify 14% of the infections in the young group, capturing around 98.8% of the total infections. Similarly, for adults, it would identify 11%, around 99.7% of the total infections. And for the elderly, it would capture the remaining 4% to detect all 100% of the total respiratory infections in this population. What about then using the typical fixed large syndromic panel? For the young, this would identify the remaining 1% of these infections. Adults, it would identify the remaining small number of 0.3%. And for the elderly, it would have been unnecessary, seeing all the infections were actually captured in the first 2 tiers. So what the data tells me, right, is that a small number of patients may need to reflex to additional targets in that second and third tier to capture the less common infections that may account for less than 50% of the cases. So it kind of like a tier approach that combines user-defined custom panels followed by a reflex testing for additional targets actually can be an effective and potentially cost-effective type of strategy for identify the respiratory infections in these different demographics. Now, if the idea is, or the goal is to create user-defined custom panels, can we really identify targets that overlap across different age groups and then create universal panels to capture prevalent pathogens regardless of age? So we analyze each target and determine the frequency and observable occurrences with all age groups in each prevalence tier. So what we found is some pathogens were commonly detected in each tier across all three populations, while others show age-specific circulation. For example, when we did analysis for group 1, it revealed that flu A, human coronaviruses, entero and rhino, and SARS-CoV-2, represented in that dark blue, consistently ranked as the top 4 viruses across all three populations with a frequency of 14.3%. Under group 2, parainfluenza and 1 and 3 was consistently observed for those patients that will need a reflex panel that goes beyond 7 targets. Group 3 then consisted of the least prevalent pathogens identified in the study, predominantly bacterial targets like the other Bordetella species or C. pneumo or M. pneumo. But then when we saw pathogens, right, that they were age-specific. Under group 1, in medium blue shade, you have influenza H1 and H3. It is consistently observed for adults and elderly in tier 1. RSV, as expected, was observed for the young and elderly. While then we saw the adenovirus in light pastel blue shade needs to be included in that first tier for only the pediatric population. Same story for the group 2. Adenovirus, flu B, and parainfluenza 2 was consistently observed in adults and elderly patients that will need a reflex panel that goes beyond 7 targets, while other pathogens were exclusively for that pediatric population like parapertussis or flu A H1. Some RSV for the adults population, RSV was observed as part of that second tier reflex panel for those adults population. So as you can see, right, the nature of these infections is very complex. So the analysis like this can actually effectively identify some of the frequencies of those pathogens and help actually to tailor maybe testing strategies that can actually lead to improved patient care. And of course, these frequencies will vary between peak or off-season and the population that you serve, but it's still important to understand in order to guide us testing strategy more effectively. Now, hopefully I've shown that embracing a flexible approach to respiratory testing as opposed to that traditional one-size-fits-all can be beneficial. User-defined custom panels that align with reimbursement policy, diagnostic stewardship, and the nature of respiratory infections can actually improve patient care, avoid that redundant laboratory testing, and potentially help reduce financial costs. So then panels such as that respiratory flex assay can offer that perfect balance of clinical information to guide patient management without deviating for diagnostic stewardship. And with that, I will hand it over to Dr. Mostafa. Thank you for listening.
Thank you so much, Kaisha. This was such an excellent and interesting analysis. And my part of this webinar will kind of emphasize some of what Kaisha just presented and complement a little bit using our own data here from the Johns Hopkins system. Just showing quickly my disclosures. And I really would like to start by talking quickly about our most recently published guidance document of the lab diagnosis of respiratory viruses that was published in May. This was a project that was led by Esther Babadi. Really, I would like to specifically focus on talking about what tests are available for respiratory virus testing, why testing should be performed, and who should be tested. Those are a few of the questions that we try to answer through our guidance document. So the testing methodology that are currently used for respiratory pathogen testing are primarily so far either protein-based, which those are the antigen testing, or nucleic acid-based, which we call NAT testing or nucleic acid amplification testing. And performance criteria can determine which assays can be selected for testing, and this really should be central in such a decision. However, where the test will be performed can dictate largely the complexity of the test. that could be tested, and also the regulatory classification. Also, the test availability and their value and the outreach are also important points. But so far, and I think we all agree on that the preferred method for diagnosis has become a nucleic acid amplification test. However, when this test is not readily available, we can consider using an antigen test. This can provide an alternative, but we should acknowledge and appreciate that this will be less sensitive than a nucleic acid amplification test. We still hear and have in the textbook that we have DFA, like direct fluorescent antigen testing, and serology and viral culture as well, but we don't recommend those for routine diagnosis for respiratory viruses any longer. Different nucleic acid amplification test technologies and chemistries, again, are available, and those include those that could also be used at home or as a point of care testing. And I guess we should acknowledge the COVID-19 pandemic for pushing the field that further. That we actually do have molecular at-home testing right now. Different methodologies like LAMP, transcription-mediated amplification, and real-time PCR, which really still the most commonly used method that we use in our laboratories. Moderate complexity testing, those we see as the majority of the extended respiratory panels, like the panel that Kaisha just presented, and the panel we are also using in our lab. Those are considered moderate complexity testing. And then there are also high complexity testing options that include either manual and also fully automated options. The panel sizes are also variable. There, for example, has been a lot of options for single target COVID-19 testing, also influenza testing. Those might be smaller panels that include also both SARS-CoV-2 and influenza. And then small panels that added RSV to SARS-CoV-2 and influenza. Those have been more popular, particularly during the influenza or respiratory viral season. Then we do have extended panel options that include 18 or more targets. Those are also available. The next question is why testing should be performed. So as Kaisha highlighted, that the majority of the viral of the upper respiratory tract infections are viral, and those are also self-limiting most of the time. Maybe they don't even require treatment. However, testing should be performed, and I guess we all agree that, and this aligns with the diagnostic stewardship, whenever the results will actually change the management. For example, if the diagnosis will help us initiate appropriate antivirals or discontinue unnecessary antibiotics. Also for infection control guidance, for example, implementing appropriate isolation measures, also cohorting patients in the hospital, and also surveillance during outbreak situations. Also, evaluation of local seroprevalence can also be an important reason of why we might consider diagnostics. But an important point to consider when we think about diagnosing respiratory viruses is always it is consistent with the tips for diagnosis in general, is the pre-test probability is very important, and it should be considered prior to testing. And I guess Kaisha highlighted this by touching on, for example, the seasonality. So also based on the clinical presentation and local prevalence of those pathogens, those are also important points to take into consideration prior to testing. Now, who should be tested? And those are actually points that I copied from our guidance. And again, because the goal is to diagnose and manage for best patients' outcomes. So we agreed that testing of pediatric patients should be limited to those who are admitted, or children with underlying conditions. And it is also, again, dependent on the season. So small and targeted panels, for example, during the influenza season, those might be sufficient. Ill patients and immunocompromised elderly patients should also be tested using multiplexed respiratory pathogen panels. And immunocompetent adult patients should be tested if the results, again, will impact the management. But we agreed that primarily testing for influenza and the SARS-CoV-2 because of the availability of antivirals for these two viruses. Now, this is our proposed testing algorithm, which considers the setting of the patients as well, outpatients versus inpatients. It takes into consideration the symptoms and the patient's characteristics, primarily the immune status, whether immune compromised versus immune competent. And then again, under this umbrella of the diagnostic stewardship, with the aims of selecting the right test for the right patient, generating accurate and clinically actionable and relevant results at the right time so that we can guide the appropriate clinical decisions while conserving the healthcare resources and reducing the cost. That includes also hidden costs that can, for example, be related to missing days from work and so on. This is what we have really proposed of when you can consider testing and when you should kind of end there and not move forward with testing. Now I will just switch a bit and talk about the specific testing options here at Hopkins and some of our own data, and give a little bit of my own perspective based on the data we have. So those are the testing options we have in our system. And this actually will slightly change very soon as we completely phase out the asymptomatic testing for SARS-CoV-2. So far, asymptomatic testing has started with the pandemic and was only exclusively performed for SARS-CoV-2, which actually contributed to the significant increase in the testing for this virus beyond the other virus or beyond the other respiratory viruses, as I will show in a minute. Symptomatic testing is performed in our institution either as a single panel for SARS-CoV-2 or a smaller panel that added influenza RSV to SARS-CoV-2. And also we use an extended panel that adds additional targets that include adenovirus, endemic coronaviruses, among others. So here, this is our testing volume for each size panel, and you can see here the testing, the very large number of testing for SARS-CoV-2 that I just mentioned. And again, this was largely driven by the fact that we were performing a lot of asymptomatic testing, especially early during the COVID-19 pandemic. But you can also see that in the purple line here, this is the testing volume for influenza, RSV, and the SARS-CoV-2. And you can see that the trend of testing shows that the extended panel, which is the teeny tiny line, triangles in black, that the extended panel testing has been stable, and it is much lower than the standalone test for SARS-CoV-2. And also the smaller panel as well. But you can also see that when the influenza season is off, the ratio of testing with the smaller panel and the extended panel, they come a little bit closer to each other. This really means that we much less infrequently diagnose patients with viruses other than influenza, SARS-CoV-2, and RSV, which I think this can be the case in other institutions as well. So then the question becomes, what could be the value of testing beyond these three viruses, which has been really a question which has been central to a lot of my research. So using the past influenza season as an example, and looking at the positivity rate of the tested samples here in this graph, rather than looking at the absolute numbers, this can show a little bit better that in the middle of that influenza season, the 2023-2024, and in the middle of what concerned everybody at that time as a triple demic of influenza, RSV, and the SARS-CoV-2, The positivity rate in our system for enterovirus was actually the highest. At that time, we were concerned about the emergence of novel SARS-CoV-2 variants, particularly at that time it was the JN.2. And we thought that this was a significant factor contributing to the rise at that time of the COVID-19 cases. But then when we analyzed the data to show or to look specifically into the clinical outcomes, we actually saw that in our system, admissions in the age groups younger than 18 were primarily actually associated with enterovirus and RSV. And this was in contrast to older age groups that were where admissions were associated more with influenza and the SARS-CoV-2. This is quite similar to the data that Kaisha showed. This indicated that enterovirus, although it is very infrequently tested for and diagnosed, is really clinically a significant pathogen. This is similar to data that we also published prior to this past influenza season, where enterovirus in our system was shown to cause outbreaks in 2022 as an example. We had outbreaks of severe disease associated specifically with enterovirus D68. This was consistent with a national trend or a national reports of outbreaks of severe illness and the admissions. Specifically here, I am showing that the admission rates in our system in 2022 was more than 27% of the infections, of the total infections with enterovirus D68. And another important point to highlight about enterovirus D68 is its association with cases of acute flaccid myelitis. So early diagnosis becomes very important, or at least an awareness of the circulation of this virus, because at the presentation of the paralysis, the virus becomes undetectable. So this just highlights the importance of making an early diagnosis when those children present with respiratory disease. In addition to entero, there are other examples. For example, here I am showing you some data in relation to adenovirus increases in 2023. Showing again the clinical significance of a different virus that we infrequently test for. And this in this year, we had a lot of cases. And again, this was consistent with some national trends. We had a lot of admissions in our system, and many of those cases, as you can see the numbers in the table below, actually required ICU level care. But that said, given the clinical value of making a diagnosis, we have to acknowledge the limitations to using these extended respiratory panels. We know that they are of high cost, and with the existing system, maybe reducing the utilization of a high cost diagnostic test is an important initiative if the diagnosis will not be associated with a change in the management. So I think this is a point that we all agree on from a diagnostic stewardship perspective. But we also acknowledge that there are hurdles with reimbursement. So specific CPT codes, for example, are available for syndromic panels that are differentiated by the number of targets. So, for example, this less than 5 can be different from 6 to 11 or 12 to 25. Also, we see a few co-detections, which we don't know then at this specific situation, whether this is a co-infection or prolonged detection of a specific pathogen. So some scenarios can become actually quite difficult to interpret. So then a tier approach then might be a solution for some of those challenges, where tiers of targets can be customized to help with mainly cost and reimbursement, and also some of those diagnostic dilemmas if we can add more targets to the smaller panels. But then the question becomes, how would you decide on what targets go in which tiers and how you will customize them? Acknowledging again that symptoms can overlap and the clinical diagnosis or the clinical suspicion lacks specificity. And then an approach, maybe you can consider generating customized panels based on the frequency of the viruses or the seasonality in specific scenarios. Which can be expected. I mean, if you think about seasonality, those can be expected, or their trends can be expected for most of the viral targets, and can be suspected also based on local or national trends. But actually, indeed, testing with the extended panels play a large role in a lot of those epidemiological data that we use for looking into viral circulation. However, I wanted also to highlight that unexpected trends can also be encountered, which can be challenging if you think about those targets and tiers. So this here is an example of the seasonality of enterovirus in our system. So we always see a lot of circulation of enterovirus, which kind of peaks in the month of September. This is another example using human metapneumovirus in our system to show the seasonality, which kind of was impacted in 2020 and 2021 with the COVID-19 pandemic. But we continue to see the seasonal trends now after the pandemic with peaks that show in our system around March and April. Just wanted here to show that our data are consistent with the data collected from the whole state of Maryland. Just to highlight that both the local and the state level trends can actually guide, and they are consistent, and they can guide decisions on target testing if we can use the seasonality data to guide the what actually can go in the tiers. But then using here the Mycoplasma pneumonia outbreak as an example of that occasionally we should expect to see outbreaks of targets that can recur maybe every many years and also show up with some abnormal presentations that might be missed if a syndromic panel was not used, if your target was not in the differential. This is a recent example where Mycoplasma pneumonia, per our pediatric infectious disease experts, presented with atypical presentations. They think the cases are presenting with more significant lobar consolidative pneumonia, and then I have to say that the extended panel in these cases were actually played a major role in making a diagnosis. A lot of those diagnoses were not really in the differential. But again, showing that our Mycoplasma pneumonia data, the local data from our institution, was quite consistent with the data from the state of Maryland. Again, showing that the local trends largely agree with the state level trends, and usually also will agree with the national trends. Then we really then wanted to understand, maybe using our local data, how we can maybe use some of those retrospective data that we have to determine if the tiered approach might have been clinically helpful, and also try to use our own data to see if we can customize our own tiers and how we can design those tiers for the right patient, right age, taking into consideration the cost and reimbursement and the testing stewardship. And this is actually an ongoing research, but I'm going to show what we have so far that we have done in collaboration with Diasorin. So the study design has been really to collect samples from patients who had symptoms and tested negative for SARS-CoV-2, influenza, and RSV, and test those samples with the new Plex Respiratory Flex assay. The added advantage of this assay, if we compare it to what we use right now, is the ability for the tier reporting approach. So this was why we were just like trying to use this panel and see if we retrospectively test those patients, and then we look into the clinical presentations, if maybe we can based on the data, calculate which tiers for our patients per age and per immune status. Just showing again the positivity rate of the targets during the study time frame, which has been the majority of the specimens we collected were tested between December 2023 and we are on, like our testing is still ongoing, but the data I am showing is up to July 2024. And you can still see here that antiretrovirus has been the highest positivity rate virus in our system. As I mentioned during that past respiratory influenza kind of viral season. So we study to date, we have tested 135 specimens from patients with symptoms, and we actually using the extended panel of those samples that were negative for influenza, RSV, SARS-CoV-2, we made additional 39 diagnoses. So of those 135, 29% of them had missed a diagnosis because they were not tested for additional targets. I think this is quite consistent with the data that Kaisha presented. And in each month, so this is the distribution of those positives per month. And it was quite consistent in each month, regardless of how many specimens we tested, we identified positive targets. And consistent again with Kaisha's data, enteroviruses were the most commonly encountered. And again, this is also consistent with their high positivity rate. But they were also followed by human coronaviruses, human parainfluenza virus type 3, and adenovirus. Sorry, this is a busy table, but I just wanted to show that when we did a review of the clinical data, it did actually indicate that many of those patients left the ED and were discharged with either an unspecified diagnosis or viral syndrome. And a lot of those patients presented with moderate to severe disease. For example, you can see here some of the diagnoses showing as group asthma, exacerbation, respiratory distress, and pneumonia. And we also had at least one patient who was infected with enterovirus, presented with pneumonia, and received treatment with antibiotics without other indication for treatment with antibiotics. You can also see that 5 patients of those 39 patients were admitted. So quite severe presentations and severe outcomes for those patients infected with those other viruses. So to wrap up and try to put my part of the talk here in context, I think we still do need some clinical outcome studies. We need to understand better the clinical utility of identifying viral etiology of respiratory infections. And it will be very helpful if we can exclude the cost considerations when we perform those clinical studies. The big question is, if we take that cost consideration out of and the reimbursement out of the equation, how will our clinical decisions and guidelines will change? I think this is a very interesting question. And also we need some clinical outcome studies that can also capture those populations that we don't really know much about, like outpatients, community, a specific population of patients who barely get access to testing. And also we have to maybe work on reducing the cost of testing, acknowledging also that molecular methods have now become the gold standard. But they also have become way more advanced. They require now minimum staff time, hands-on time. So maybe we can also work on bringing the cost down. And I do think and believe that with the current model of high cost and reimbursement, a tier approach for selecting the targets can be a solution, and the data can guide the selection of the targets that go in each tier, which can be based on local or state level data. But again, reducing the cost can be and should be an ultimate goal. With this, I would like to thank you so much. Thank you, and thank Diasorin for the really nice research collaboration, and also a big list of funders that funded some of the data that I presented today. Thank you so much.
All right. Thank you both for your very informative presentation. Now we will go ahead and move into the Q&A portion of the webinar. Remember that if you have not already, you can submit any questions that you may have below in the submission box for our speakers to answer live. Okay, it looks like we do have some questions filtering in here. Let me take a look. Okay, the first one we have here is, how do flexible testing options support efforts to prevent antibiotic overuse?
I can go first.
Yes,
Kaisha,
go
if you
ahead.
don't.
Go ahead.
I think this is actually one of the important questions we are trying to answer based on the on our research and the data we are hoping to collect. But I think especially for elderly patients, maybe not very much the pediatrics. If a patient presents to the ED and they don't really get, like, they present with upper respiratory infection, they are highly likely actually to receive an antibiotic. So I think if we start making if we start making those diagnoses, if it's a virus we don't treat with antibiotic, I think we will actually make a huge impact on reducing antibiotic use. There are some approaches right now that, for example, viral versus bacterial kind of panels that some institutions are trying to investigate. But I think an easier option might be as simple as testing for a respiratory virus pathogen. And if the cost is a limitation, then this tier approach will make it actually feasible. Kaisha, if you would like to add.
No, that's actually pretty much my response, right? So the biggest issue is that diagnostic uncertainty when it comes to symptoms, right? So sometimes you cannot differentiate, as Dr. Mostafa mentioned, right, from the elderly population as an example, you cannot distinguish between bacterial or even viral infections. So because of the high risk population that elderly patients they probably gonna give antibiotics just to make sure. So as she mentioned, right, the idea is to really understand the patient or the patients that you are serving in that hospital in part of the testing. So not just drive that targeted testing that is the typical flu A, B, RSV, SARS-CoV-2, maybe actually expand a little bit more with that tier option that captures additional, more prevalent, like enteral, common cold, that will serve much better that population. It will give you a better diagnosis there, and then allows then the avoiding that inappropriate use or even de-escalation in that sense. So I think that's the idea, the flexible, that again, it's all about cost driven. And if that patient already selected that tier, first tier, you can just go back for more results. And again, you pay for what you select. So it's just that balance of that clinical utility to avoid that overuse of antibiotics. But then at the same time, as a laboratory, is just to keep that cost to minimum. So great question.
All right, perfect. Let's take a look at another we have here. Okay, this one says, can you provide more details about how the user-defined panels work and insight into the criteria for creating these panels?
So yes, so at least for the software from the instrument itself, it allows you to actually select any target within that 19 available in the respiratory panel. So it's very a la carte. You can select one by one before you are going to do that testing for that patient, or you actually can save predefined panels and use those predefined panels that you created based on either tiers. If you have within the winter, you have a first tier winter panel, reflex panel. I mean, you can be creative in those type of custom panels that you create, and then use that as a prior to running that patient sample. At least for the criteria to creating these panels for my study, everything was based on the size, the typical targeted testing algorithms, and the current reimbursement constraints that they are right now. So when then selecting the targets for my 3 tiers, we just consider the prevalence in each of the demographics, just to be a little bit more consistent of the population that we were testing.
Yeah, I think a fantastic long-term goal or vision is like the provider can, based on the criteria of the patient, whether pediatric or older age, immune status, what is circulating right now, the seasonality, can then just go and select the targets. And hopefully this can be through also some guidelines that can be standardized. And then they can select the targets based on all those variables. And then they can then select a second tier if this tier is negative. But I have to say this will be a very large project from a lab information system kind of perspective. So this is also like an important challenge that we need to highlight and think of.
All right, wonderful. Thank you both. The next one that we have here says, what are some challenges you anticipate in moving away from targeted testing and fixed syndromic panels?
I would say, as Dr. Mostafa say, right, the implementation can be the implementation and the education behind things. We are so accustomed to that already, targeted testing and the fixed syndromic panels. So we have a really great understanding when it comes to that targeted testing, like the flu A, B, RSV, SARS-CoV-2, right? A lot of is that driven by guidelines. And then we know also the transition to the syndromic panels, also there's a lot of guidelines. Who is the patient, pediatric versus elderly versus adults, and their high risk type of criteria to consider when you transition to syndromic. But I think looking ahead, the idea is to move away from that limited targeted and possible fixed syndromic panels. So if we are going to try to move forward, I think the idea is to embrace new guidelines. So guidelines needs to be happening in terms of how custom panels can be implemented for the lab, what are the criteria, how they can be created. So I think new guidelines is a good starting point to potentially help with those challenges, as well as then conducting some outcome studies to clinically demonstrate the benefits, of course.
All right, wonderful. Thank you. Here's another one. It says, how do you envision implementing a tier-based approach in the laboratory? And what challenges do you anticipate regarding cost, reimbursement, and testing stewardship considerations?
I think I think we kind of answered this already. Again, the data will have to support how we will design the tiers in general, how many targets will go in each tier. If this will be guided by reimbursement, for example, should we max the number of the targets to a 5-target kind of tier 1? And it should again be based on local data, population of patients, and so on. But then if tier 1 will reflect to tier 2, then I'm actually really not sure how this will work from kind of like reimbursement perspective or like cost. Again, I mean, I still think that we have to work on this as a root cause analysis of a lot of like going around guidelines that we are trying to like work around and try to reduce the cost in general. But implementing that tier can be like a temporary solution until we get there. But I think we now, for example, in our institution, test for influenza, RSV, and SARS-CoV-2 and the respiratory season for symptomatic patients. So if we acknowledge, for example, that we always also have, or we might have a lot of circulation for enterorhino, so I think we can easily decide that we will add entero to our tier 1. And then based on what is also circulating at that time and causing a lot of admissions, we can decide on what can be added as a 5th target. Also, you can decide if you want your panel to differentiate influenza A and influenza B as 2 different targets, or if it will be sufficient to just diagnose it as a 1 target, which is influenza. So I think all of those are questions that have to be supported by data and outcome data. And they might be, at the end of the day, geographical location specific or institution specific.
All right, perfect. Okay, it looks like we have one final question submission for today. It says, knowing the importance of testing beyond just influenza, RSV, and SARS-CoV-2, what specific targets are you considering for the tier-based approach?
I think per my data and for my institution, I would definitely add enterovirus to our tier 1 if I to make a tier that will include additional targets. And then I might consider adding adeno or others like the or human endemic corona. It will be actually tough to select what will be the 5th target in tier 1, or if we decide on a 7 tiers, what will be the other 2. But definitely entero is an important one based on my data. Kaisha?
Yeah, same. Based on my data, it will be entero, rhino, and adenovirus, and then human coronavirus. Those were the 3 major viruses besides SARS-CoV-2, influenza, and RSV. So,
all right. Well, thank you both so much. Do either of you happen to have any final comments to share with our audience today?
I guess it's almost the respiratory season of 2024-2025. So stay safe and get vaccinated whenever you can.
yeah, thank you again for listening. Please listen to Dr. Mostafa on getting vaccinated. Stay safe out there. Respiratory season, it seems it's gonna be probably very hectic, based on the Southern Hemisphere numbers. So stay healthy out there. And thank you again for tuning in. And if you have additional questions, please feel free to reach out.
All right, wonderful. Thank you again to both of our speakers for your time today and for your very important research. Before we go, I would like to thank the audience for joining us today and our sponsor, Diasorin. Any questions we did not have time for and those submitted during the on-demand period will be addressed by the speakers via the contact information you provided at the time of registration. This webinar can be viewed on demand for 1 year until September 5th, 2025. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.